Thank you everyone for joining us today. My name is Maya Mendez. I'm the Telehealth Program Manager at West Health Institute. And in this session, we'll discuss telehealth initiatives and their impact on improving access to care for older adults in rural communities. So we'll start with a presentation by Becky Harless on the telehealth services at Vandalia South Charleston Area Medical Center, followed by a panel discussion with other experts in telehealth and rural health space. And today's speakers represent the Collaborative for Telehealth and Aging. We have Becky Harless from Charleston Area Medical Center, Greenbrier Valley. We have Katie Darling from Dartmouth Health, Dr. Walker from Aval, David Fletcher from Fletcher Health Consulting, and the panel discussion will be moderated by Frank Seitz from Jefferson Health.
Good afternoon. I'm Becky Harless. I am the Vice President Administrator of CAMC Greenbrier Valley Medical Center. Greenbrier Valley Medical Center was acquired by Vandalia Health, which was where I have worked for the last 13 years, in January of 2023. So it was a good move for me to move into this role. Previous to that, I did I did all of the telemedicine at CAMC and Vandalia Health, working through all the way from starting at kind of telestroke to building out what the program would look like and grow into, strategic planning, to, the dreaded word of pandemic. When pandemic hit, that we already had a telemedicine program in place and moved forward into where we are today, which we'll talk a little bit about through my presentation. So what are some of the conditions that lead to access issues that are ripe for telemedicine? Rural comes to mind when you think about access issues. And if you look at the current Census Bureau ranks West Virginia the third most rural state in the nation, and the only state that is entirely located in Appalachia. So what's that really mean? That 55.4% of the population lives in a rural area, and 81.3% of the land is rural. Some more statistics to kind of go along with that. West Virginia also has the second largest senior population in the U.S., with 20.5% of the residents being 65 or older. By 2035, that statistic is predicted to grow to 1 in 4 West Virginians will be 65 or older. In those 11 years, I'm still not going to be that age. So that statistic won't include me. What are some other issues when you look at conditions that lead to access issues? Mountainous terrain. So West Virginia is kind of nicknamed the mountain state. When you think about that and where we land on I'm going to skip social determinants of health and come back to it. On broadband access, West Virginia is in the bottom 10 states for broadband access, which it kind of makes sense because of the mountainous terrain. It's really hard to run the fiber and get that connectivity out there. But if you're living in Delaware, New Hampshire, New York, or DC, you're in the top 10, so you're in good shape there and should be able to use some of these ideas that we present today. And then thinking about social determinants of health for conditions that lead to access issues. That doesn't have to be rural. That doesn't have to be broadband issues. We all struggle with these issues. If you think about transportation, I've worked in urban areas where, patients a mile away couldn't get to the hospital to get the care that they needed because they had transportation issues or food insecurities and those things. So that all kind of leads to our access issues and where we came to build in a telemedicine hub. So what is the definition of a telemedicine hub? You can really kind of make this what you want it to be, but typically it is a really small bricks and mortar footprint that provides all the technology needed for a telemedicine hub. So you use your telemedicine technology vendor, put in their equipment, has a small staff. So typically one RN, we use RNs at CAMC, and two exam rooms, 1 to 2 exam rooms. You could really get by with one, a small check-in area, office. You need a little triage area so you can get your height and weight and those types of things. But that's what we've defined as a telemedicine hub. We've done it a few different ways, but that's the footprint that you need no matter where you put one. Next slide. So how did this all start? The telemedicine hubs for us started as an experiment, and it really was born out of a particular visit looking through telestroke. So we were going to a site where we had telestroke, and a partnership with telestroke, and we were going to looking to set up telecardiology. So the cardiology manager was riding with me and realized it took 8 hours. It took a whole day to drive to this hospital site, have a meeting, and drive back. So on the way, I just asked the cardiology manager, what happens if you have a cardiac event and you live here? And she said, well, typically you go to the hospital, go to the ER, get in a helicopter, and go to Charleston, get the care you need, get on the mend, and they send you home. And I said, okay, well, what happens then? And she said, well, they typically don't come to their follow-up appointments. And I said, okay, then what happens next? And she said, well, they probably have another event, end up in the ER, and get on a helicopter to Charleston again. So that story is well known across, our entire organization, because that's really where it started. We had something we needed to solve for. We needed to solve for that patient, which, you duplicate that patient all over the state. And how do we get the care to them? So that's really the experiment that started. And then thinking through that, we needed the right staffing. For our physicians at the time, they really wanted a nurse in the setting, so an RN. Now, to say that we have a nurse in every telehub now, we do not. We've kind of challenged that model a little bit, but typically it starts with an RN. And it's really not a bad idea, because it's a whole system of care that they work through. So they look at orders, they look at other visits. They've got the time to look into those types of things to make sure that the entire visit is being done. And actually, I've had them where they see, oh, I see you're going to Charleston to see this specialist. Do you want me to try and see if we can set that up via telemedicine? And then we've got a couple different models. Our very first model was a standalone. Think about like a strip mall, right, with no other healthcare things around. And we leased the space, got it going. Volume wasn't really picking up. If you think about it, like sort of like a AT&T store or T-Mobile store, that's how we designed it and what we wanted it to be like, so people could just come in and even do an urgent care visit if they needed to via the telemedicine equipment that we had in place. What the second site that we did, we partnered with an FQHC and leased space from that FQHC to create the clinic. And that was really where we started seeing the economies of scale, because our employee was really embedded in their staff. So when there was referrals, or that type of thing, they got really well acquainted. Or if there was even just a patient problem, they'd reach out to her and say, hey, can you help us solve for, this? We can't get this patient to Charleston, or we can't get this kind of access. So there was a lot of growth just in that clinic as she worked her way through and became part of that staff. So what were some of the surprises? Some of the surprises were, I think when telehealth first started out, we all narrow-mindedly kind of thought that this applies to the younger population. And I think all of us were really surprised to see how well it does work for the older adult population, and that a large percentage of our visits are with the older adult population. I love to pull the volume data and look at the 90 to 99-year-olds that are using telemedicine throughout our system. And it's not a huge percent, but it's 5 or 6%, which is pretty incredible if you think about it. Some of the other surprises were the market share. When we did some evaluations of the data in that first year to pull when we would put a telemedicine hub in a market where we didn't have a hospital and didn't have a lot of business. About 99% of the patients were new to our facility, so hadn't been seen in the facility before. And then when they needed intervention, that came down to, they were going to our hospital for that intervention. So we like to keep the care local. That was a big part of our design model, was any kind of lab or imaging, those types of things that would be ordered from these visits would be done in the local community so that the patient had, more access to be able to get those things done. A lot of behind the scenes work with IT and other departments just to make sure that results carried back and forth and that we were able to get that. But that's also a big part of what that telemedicine navigator or that nurse in the hub does as well. If a result isn't routing, that person will call and say, hey, I need so-and-so CT scan results. And they'll make sure that it gets into the physician's inbox to be able to be looked at. Some of the other really interesting things that popped up were the use cases. We have a really robust use case now. It started out with really cardiology. And then neurology popped in, and we got a lot of resistance from the providers in the beginning because I think it was new and you really have got your mindset around this is how I perform a visit, right? And it's in person and I watch them walk or I do this. So there were some denied visits in the beginning, so denied referrals. And I would just make a call and say, hey, help me understand this so-and-so patient and they're 2 hours away and don't have a driver's license because of their neurological issues. So they're not able to drive to get to you. And then it was sort of like this aha moment. Oh, okay. Well, I think we could probably do the visit via telemedicine then. And our use cases grew organically just by saying, why not? Right. And it's not a overly administrative response of you've got some administrator coming and telling a physician you have to do this. It was more of a individual patient need, and they felt like, well, let's try it. And once they did one, then nobody had to intervene after that. That referral worked seamlessly after that. They were really pleased with the technology and what they could do via telemedicine. So the other thing was volume growth. We saw a large volume growth, especially in those hubs that are attached to FQHCs or RHCs or primary care offices, or they have a really strong connection in the community to those. But I will say that all of the hubs are not created equal. And, we'll kind of go over that later. And I'll back up to talk about the use cases again. I did get a call once that said, can we do a hip replacement evaluation at one of the hubs? And I was kind of like, I don't know. We can ask. And so we asked the orthopedic surgeon and they ordered all the imaging and it worked, So it's just, I think the important message there is just to kind of challenge the status quo of can we or can't we? And most of the time, the patients, once you challenge it, if it comes back a no, they're willing to make the travel. If they're able, they're willing to make the travel to the hospital. So how's it going? We started with one hub, grew to 2 hubs, and in 2 to 3 years, we have 12 hubs with plans for expansion to. We try to do at least 3 a year where we expand. We've added a mobile fleet, so we have a mobile unit that goes to even more remote locations and provides care. So what you're looking at across all of West Virginia is hub stops, hub locations, and then mobile unit stops. And then if you look at the green tabs, that's where the future hubs are. Like I said, there's varying volumes depending on where you are. Our most busy clinics are kind of the 2 bottom right pink ones, at a town called Princeton and a town called Lewisburg, which is actually where I am. Those are attached to, the Lewisburg one's attached to a very busy, very large FQHC, which has an attachment to the West Virginia Osteopathic Medicine School. And then the Princeton hub is attached to a very busy primary care office that is a CAMC physician. So those tend to work really well. Again, dedicated staff is really important. Some of these, the current focus hubs, those are coming from one of the hospitals that we worked with to acquire. So that's Mon. And they typically do one or two specialties. So they focus on cardiology, or they focus on cardiology and neurology. We see about 350 visits per month. And some of these, we need to evaluate. Others have really large volumes and tend to be really great for the patients. And then we've come out of this with building telemedicine only providers. So when you look at a couple of specialties that just make sense, is we had a endocrinologist who was just physically not able to come into the office any longer, but still really wasn't ready to retire, wanted to continue to contribute. And so we set up his home office for telemedicine. And it has been one of our biggest success stories. We had found that, in some of our northern markets, that we were referring all of those visits out to a very large competitor of ours. And we were able to put this in place and create one of those focused telemedicine hubs for just endocrinology and take care of the lion's share of those patients through doing that. And his patient satisfaction scores are through the roof. Another one is infectious disease. We've hired our first infectious disease telemedicine only provider who does not live in West Virginia. We have nephrologists who are telemedicine only and provide visits throughout the hubs that are telemedicine only as well and do not reside within the state of West Virginia. We have some that do and some that don't. So these are some of the services that we provide using telemedicine. I'm always impressed when I go into the hub and there's an oncology visit, or that's a hard visit anyways, and it's really difficult to have to travel for that. So we've been able to really expand our services at these clinics. Weight loss is a big one. I'd say the major volume is going to be endocrinology, weight loss, cardiology, neurology. Those are kind of the lion's share, and behavioral health. There's a lot of behavioral health, but we do see patients in all of these. So what are the plans for the future? Like I said, all the hubs are not created equal. And so I think we've got to take a really hard look at the hubs that have the large volumes, and then the ones that have the smaller volumes. Is there something that we can do different, right? Can we connect with partners better in the area? Can we, is there a reason to be there? So is there a market share reason? Is there a competitive advantage? Those types of things. But we're going to have to do that in the next 12 months, I think, on some of these hubs, and then double down on the ones who are really performing and maybe expand them, make them a little larger and have more staff, because they seem to be really busy. And the way that we set it up as well is it's around the physician's availability. So the physician doesn't necessarily block out 4 hours for telemedicine. They can be working in their office hours, seeing patients in the office, and their third appointment might be a telemedicine appointment in Lewisburg, West Virginia, and their sixth appointment, maybe a telemedicine appointment in Morgantown, West Virginia. So they kind of just flip in and out, and that kind of keeps from taking up too much of their time, but also being able to manage the schedules at the hubs to be able to move those patients through. The volume. So like I said, we're increasing. We've got plans for 3 more hubs. I think it will end up being more than 3 as we evaluate some of our outlying clinics with our expansion. CAMC grew from 3 hospitals to 17 hospitals in something like 18 months. And with that, we acquired a large amount of outlying clinics. So, for instance, here at Greenbrier Valley, I have a clinic in Virginia. I have a clinic in Peterstown, West Virginia, which is an hour further out from where I am. And those just make really good sense to create those telemedicine hubs. So we've got in the plans for 3. I really think that will grow, a lot more. And then the use cases are going to continue to grow as we have that patient that pops up and says, can we do a hip evaluation? I don't know. Yeah, it turns out we can. So the use cases, and I think just the use cases across telemedicine in general are going to continue to just grow and grow as the comfort level grows with telemedicine. And then, hospital support and PAT. So this is one where we're going to see a lot of growth is with perioperative and PAT visits that currently we're revamping and working with a large group to revamp our PAT process because it's kind of different depending on which hospital you go. So as we come together as a system, we'd like to have that experience be the same for each hospital, right? And how does that, do you have to come to the hospital? Some hospitals demand that, some are a little more flexible. We do phone PAT here, we do others. This is one that we've started piloting, and I think it's going to be extremely successful with these outlying hospitals or outlying clinics and hubs, just to be able for that population to not have to make 2 trips to Charleston, one, for PAT, go back home, come back a few days later for their surgery. So I think that one's going to be a huge use case for us. So what are some key considerations? If you've made it this long and you're thinking about, hey, a hub might be right for you, the talk about what works the best is really that partnership model. So the large FQHC or RHC or even, I don't know if you have Alidate in your areas, but, partner with them to set up a model. These are really non-competitive. So you're keeping all of the ancillary services in their market, in their offices, and just seeing the specialty care. And that's really been a win for us in our approach to, even as we've acquired these hospitals, is we've been more of a partner and a facilitator and I want to see you be successful. How do we see you be successful? And I think, it really started with us when, you open up Becker's and you see this many hospitals are closing, this many hospitals are closing. And being a level 1 trauma center and the tertiary care hospital, we need those hospitals to exist. We need them to provide care in the communities because you can't take all of that on. So the partnership model has really worked out for us. And I would think that would be the priority. If I was looking for a place to set up a hub, I would look for the partnership model. The next thing is the right nurse. All nurses are really not created equal for this role. If you're in your hiring, you really need that utility player, somebody who is going to learn registration, learn, medical records, learn how to just transition patients through the system, is willing to go and meet with the physicians in Charleston to see, how they like their patient worked up, because it's different in urology than it is in cardiology, than it is in endocrinology. So that's been really important for us, is finding the right person who's willing to do it all and be, the voice of the patient in all of this. And then, the continuity of care, of being able to provide the services needed in that community and the connection to your larger hospital system or your team. And then lastly, the pull instead of the push. So this has been our approach up through now is, we're not overly administrative with the physicians to grow our business. We do about 10% of our visits are via telemedicine. And we really haven't been administrative and said, given a quota, you've got to do this many visits. It's all been organic growth through either somebody who's just really a doctor or provider who's just really interested in telemedicine and they want to provide this service, or those patients who can't get there. And we had the conversation of just, well, help me understand why wouldn't we see this if they can't drive here, or there's this barrier or that barrier. And that's really how we've grown our model to get to where it is today. Any questions?
Becky, great presentation, good insights. One of the things I found pretty interesting was the fact that you have 5 or 6% of your patients that are moving into their 90s using telehealth. My first question to you is, are you finding that families are the conduits of facilitating those telehealth visits with those patients, or is there just as many, patients that are aging that are able to navigate your systems and to conduct a telehealth visit?
So I think it's a blend. I think it's the telemedicine hub is really a bridge between the picking up their own device at home and understanding how to do that, to a brick and mortar, but still telemedicine because the physicians coming in. So I think a lot of that volume is really coming from the hubs. And then the rest of it is from, hey, mom, I think you should try this visit. And then with our telemedicine vendor, our hardware vendor, if you will, we have a way to just send them a link. So a lot of them can text, right? And if they can get a text and hit the button and they're in, it simplifies it from creating an account and doing all that. So that has really increased our volume in that older group.
That's great. One of the questions that came in was, are all the hubs open 5 days a week, 6, 7 days a week? How do those schedules and the volume, how are they set?
So it's typically 5 days a week, and the volume is set. So if I'm the navigator at a hub and I get 3 referrals, just, one's for neurology, one's for cardiology, and one's for endocrinology. It is my role to work with those specialties in Charleston to get it on the doc schedule. So that's really so there's a lot of administrative time involved there in getting those. And then that sets the schedule in the EMR based on when the docs are available. And then we ask them to kind of be sales reps, if you will. Sure. So in their downtime, we want them to go out and be visiting with providers in their local market to help them, to show them that slide of all the different services that we can provide. Because, how many rural areas have, access to neurology or have access to, most of them don't have that kind of an access. And so we ask them to be salespeople in that administrative time and go out and just connect with providers. Plus, it makes it easy. They'll just hand you, here's 10 referrals. Can you just schedule these for me?
Yep. So another question came in that was asking whether or not you only use a hub model, or is there some other variations of telehealth with seniors that you're implementing?
Absolutely. So we, all the traditional models are still there. So, the Charleston visits with Charleston is kind of our home hub of all of our specialists. They do the text link, so you can have a visit from your home, anywhere. We all of the traditional models are still there. The hub is there for a little more complex, and really it was a good bridge for the providers who were a little nervous about it and who still want a height and weight and some vitals and a nurse looking at them, right? It was a good gap closure for us to build volume.
That's great. Well, thank you. I think, we're right at time where we need to move into our panel discussion, but appreciate you sharing all the innovations that you're working through. It's certainly, I think, as a lot of us who do telehealth on a daily basis can attest that it's, you have to be a little bit crafty in how you get people's attention and how you help solve their problems. So I thank you for your discussion today. So with that, at this time, we're going to move into the panel portion of our session. And so what I'd like to do right now, I'd like to introduce a call on each of our panelists to introduce themselves, and we will get into the session. I am Frank Seitz. I am the Vice President of Connected Care Operations here at Jefferson Health in Philadelphia.
Again, Becky Harless. I am the Vice President of Greenbrier Valley Medical Center and telemedicine.
Everyone, I'm David Fletcher. I'm the president of Fletcher Health Consulting. Previously, I was the VP for telehealth at Geisinger in Pennsylvania and also University of Arkansas for medical sciences in Little Rock, Arkansas.
Awesome. Thank you. And Katie?
Hi, I'm Katie Darling, the Director of Operations for Telehealth at Dartmouth Health.
And Dr. Walker?
Hi, I'm the Medical and Clinical Director for the Senior Care Program at Aval eCare.
All right, so our first question today really is, how does telehealth change the healthcare experience for older adults in rural areas? And can you provide some examples of improvements you've seen, anything around data for providers or patient surveys or any other anecdotes you might want to add? And I'll open that up to the group, whomever wants to jump in first.
I can kick it off. We did a lot of surveys at Geisinger, and because somewhat similar to West Virginia, our population in central Pennsylvania skews much older than the general population, so we were particularly attuned to it, and we found that there was high satisfaction for among our older patients, which we were gratified to see. And one kind of interesting thing was when we compared. We used Press Ganey, and so we were able to look at other institutions all across the country, a major surveying kind of organization. And we found that amongst our older patients, we actually had higher satisfaction than that same age range for across the country. And I think the reason for that was much like Becky had touched on, where we had the same process where we could just text a link. We didn't require folks to kind of go through an elaborate portal and trying to create an ID and password and that kind of thing. And so I think that, kind of highlights there is benefit sometimes to kind of thinking through your patient population. And if just making small tweaks to your design can make an enormous difference, for those kind of older patients.
So you attribute ease of use is the factor that's crossing the bridge a little bit.
Yeah, I think so, and largely based around, we also allow them to put just kind of freestyle comments, and many times I saw comments about I didn't think there'd be any way I could do this, but it was actually really easy. And one other comment I always like to think about, just it was an older patient as well, and he was talking about he was getting treated for a brain tumor, and that telehealth, it was a use case I would have never thought of, but that telehealth helped him specifically because just being on campus and getting in the elevator was, would make him sick with the tumor, and it was just awful for him. It was never a thing that I would have thought of, just avoiding elevator rides, but it's those kinds of things that just being able to be in their home and make the experience so much better for our patients of all ages.
That's great.
So I've got kind of an anecdotal, in the previous iterations, you continually improve your offering. And the previous offering, you had to create an account. You had to go to that website, you had to create an account, and that seriously limited the ability of especially that older population and being able to ask a whole bunch of questions. At one point, to counteract that, we even had sort of a call center set up that would have somebody do it take their information and fill it out. It would send them an email, and then that would get them to the point where you could create a link. But we went to our vendor and said, listen, we can't keep doing this. It's limiting our ability to provide this service. And so that's how we got to the link, right? The text link. Everybody can click a link. And then another thing is just visiting the hubs and talking to the patients. I know we had a patient who his cell phone didn't work at his house, and there's no service there, no anything, and reminder calls had gone out on his cardiology visit. Well, he had a telemedicine hub visit set up for something else, another specialty. And he was an older gentleman. You know, they were able to see that he had missed all these visits because he showed up for his hub visit. And before the navigator would let him leave, said, "Are you able to make it to Charleston?" And he said, "No, I'm really not able to make it. And I haven't gotten these reminder calls. I don't get any kind of service or reception." And so she said, "Don't leave." Called the office, gets it set up, and got his cardiology, again, that pull versus push, got that appointment set up. He came back the next day. He did come, and he said, "This is the best service." You know, just those are the things that make you say, "I love what I do," right?
That's great. So what I'm hearing is fluidity. You know, just how fluid do we make it for the patients and remove those barriers?
Can I speak up a bit? And so we work with people that are living in nursing homes and assisted livings. And what we find, particularly in the rural areas, is that there's a lot of those residents have a primary care provider who's primarily doing clinic medicine. And so when they have an issue that comes up day or night, it's not easy for the clinician to leave a full schedule and come over to the nursing home and evaluate what's going on. And so what would be the default would be to, if they were having a new issue, is that they would get sent into the emergency room, which is a real challenge, not only from a cost standpoint, but also, transportation is challenging everywhere. And so what we've found is that we're able to do a telemedicine visit. It really helps improve people's access to care in a timely manner. Also, it reduces the amount of time that the staff is spending on just preparing somebody for a transfer. And it allows us to get a much better history because we're able to include the direct caregivers in the history gathering. So we really understand what's going on of concern from the caregivers that know them best. And over 95% of the time, we're able to address the issues and get them taken care of without it ever being necessary to leave the nursing home environment. So that's been highly successful. Most of our customers are in, I would say, more rural areas, although, frankly, we found this, this is a challenge in urban areas too. So it's not unique, I would say, to the rural, although oftentimes the distances to transport to the local ED might be a lot higher in the rural.
Yeah, I would have to agree with you. In Philadelphia, I don't think anybody would say that we are rural, but certainly we have patients, a handful of blocks away from, our center city hospital that just can't physically get here, right? So, how do we cross that bridge? How do we create access in different and unique ways? Katie, did you have any thoughts that you wanted to add to this?
Yeah, in regards to some of the improvements that we've seen a lot of improvements in regards to telemedicine. So we pulled some data to see for 65 and older during the beginning of the pandemic, primarily audio only was being used. So 60% of all visits delivered to patients at home was audio only because they didn't have the technology or they didn't know how to use the technology, broadband, to actually have the video portion of the visit. And currently we have come pretty far. They're only 30% are now being delivered by audio only. And while we've seen that improvement in video, our failure rates have also decreased for those 65 and older. So we measure our failure rates by telemedicine scheduled as audio and visual, but only delivered by audio. And we've seen a decrease from 16% to 10%. So really great improvements in that area. And another thing about how it's changed the experience is I pulled the data for our virtual urgent care for patients 65 and older. One of the questions we asked them is, what would you have done if not for telemedicine? Not for this service, what would you have done? 18% said they would have gone to the ED. So great, by supporting telemedicine, we saved those ED visits. But more importantly, 18% said that they would have not gotten care or they would have delayed seeking care. So really this change is providing opportunities for them that they didn't have otherwise, and really getting them the care that they needed when they needed it.
You know, and those are important points. And we hear often about having the audiovisual visit and how, from a provider's time and billables and things of that nature. But the flip side is that if the only access to the data you just showed, if the only access is to a audio visit and a patient was able to get to their next actionable step to deal with whatever's going on with them, there's the win. There's the win for what we're providing for people. So with that, the next question I have for the group is, what telehealth strategies have been effective in overcoming workforce challenges in rural areas?
One thing that we've done in our area is seeing how you can kind of share resources. So luckily, if your health system is having a barrier with supporting a full-time FTE for nephrology, it could be that hospitals close by to you are also in that same situation. And can you kind of come together and each one of you say, we could use 2 hours a day and use that nephrologist to do it via telemedicine instead of that, traditional in person. So a lot of thinking about how can we pull things together to kind of share this resource and provide it via telemedicine instead of that traditional in person.
On the other side of Katie's example, that was a physician. So in our hubs where we lease space sometimes and don't have that dedicated person, we will lease the employees from that hospital. So lease them for a few hours to do that. And that makes a lot of sense in some of those lower volume hubs and it's kind of a win-win. They don't have a full-time FTE sitting there for a few hours with idle time. We'll lease that time and use that to get access for their patients to specialists.
So Becky, a follow-up question to that is, how do the staff feel that are being leased out in this capacity? Do they enjoy the work that they're doing in that manner? Do you have any data on that?
I sure do. I have every employee that we have in that model is thrilled about the work that they do, that they are providing something to their community that has never been done before, right? And in these small communities, I'm in a small community now. Everybody knows everybody. They're related to everybody, and they feel so good about being in healthcare. And it's kind of like changing that whole thought process that's around healthcare right now. So it's just a feel good moment about loving what you do and connecting people to the care that they need.
I mean, I think a couple of things, that, very similar experience, but, in central Pennsylvania, particularly some of the specialties that are kind of hard to recruit in general across the country, it's even more acute in, kind of rural areas that just, they don't have the amenities that some of the, folks coming out of med school are looking for these days. And so it really gave us another tool in that, we would actually enter into contracts with, say a company that would provide providers licensed in the state of Pennsylvania, that they could be physically located anywhere. And it was particularly important for behavioral health. We were doing 85% of our visits, outpatient visits, via telemedicine. And so it opened up a whole new pool of potential providers that we could recruit because we didn't have to have that kind of relocation piece. And the other kind of corollary to that is nice is also extending careers. So even the folks that we had locally, so particularly in nursing, we started a virtual nursing program, and it was huge for us because there were a lot of some of our nurses who just physically couldn't work the floor or lift somebody out of a bed. We were able to extend their careers because they could do the admits and discharges and things like that all remotely.
There's a future for me.
We've also found that for assisted livings, that virtual nursing has been really helpful for providing RN expertise in the assisted living environment, where they oftentimes will have a nurse that is the nurse, or maybe the nurse that's shared with the nursing home that is on call for on top of the regularly scheduled hours, and that's a recipe for burnout and turnover. And so what we have found is having a virtual nurse available to do nurse assessments and nursing work so that lone on-site person isn't overburdened has been tremendously helpful in retention and success of that nurse on site.
That's great. So great conversation so far. So for our last question for our panelists today, could you provide some examples on how stakeholders in your region, or such as governments or community organizations and the like, how do they collaborate with healthcare systems to expand telehealth services, and how are those communities addressing the digital divide?
I can jump in there. In West Virginia, we're really fortunate with our state senators are very involved. And I was actually invited to be on Senator Capito's broadband team from a telemedicine perspective to talk about, how important. And I'm very sure that some of the, presentations that I've done with her, she's taken to Capitol Hill to talk about what we're doing to address that divide and be able to do that and get dollars pulled down. I think she's been able to pull down a lot of dollars from the FCC just to address that broadband. Again, we're in the bottom 10 states across the US for broadband access. And so, the hope there is let's put these hubs out of business and get everybody access at their home, right? The hub is kind of a temporary measure until we're able to improve our entire state. But we're very fortunate with, how involved they are.
We're headquartered in South Dakota, and so we're actually in 42 states that we're servicing, but South Dakota is our home. And the state of South Dakota has really been doing some innovative things with funding to bring telehealth into new spaces. So I work primarily in the senior care service line, but we have 9 other service lines and that are taking care of people of all ages. And I think some of the really innovative things that have happened recently are that the state of South Dakota decided to invest in creating EMS access to telehealth. So now our ambulances have access to a board certified emergency room physician and nurses while they're in a remote scene picking up a critically injured person. And they can start that treatment. They transition to the emergency room that also has access to that same team, who can then help, facilitate, the transfer urgently. And it really shaves off critical time that it takes to get somebody that has really, really difficult injuries to a tertiary center for treatment very quickly. They're also doing similar type of work. They've created access to our police officers who are responding to mental health crises, and they can access behavioral health right from the police officer's vehicle, so that they can get an assessment and have that support too. We're really excited that now they've also decided to expand and invest in infrastructure for expanding the service in nursing homes and assisted living. So the state just approved a $5 million grant to do that. So we're in the midst of fleshing that out, as we speak. We'll probably have more information on that by the end of the month, certainly next month, if not this month. But anyway, so I think that we're lucky that the state has really leaned into what else could we do, and how do we think about this differently?
Yeah, that's awesome. The great programs that they're implementing. It'd be great actually to hear, maybe in a few months down the line, once things come through, to get an update on this session and on where that's going. Because I think that would have a lot of implications for many states as a seed program. Katie, anything that you wanted to add?
Yeah, similar to like what Dr. Walker was saying with extending access to the community organizations. In the beginning of the pandemic, we were having a lot of issues with, residents in the SNFs and ALFs and rehabs not being able to come to see their specialists. And if they could, we needed transport or an ambulance to bring them there. So we really had to rethink, how can we still provide this care that they need while they're there, but, build through all the barriers. So we did a huge project with the SNFs, the ALFs, the rehabs in our area, and ended up contracting with 30 plus facilities in order to provide our telemedicine services to them via our specialists. So got them set up with the technology that they needed to connect, the right training that they needed to help the residents do that, and then the ability to also extend those links to their community resources so that any caregivers that maybe need to be involved with those visits and the decision making could also join them during those visits. So really trying to reach out, and provide that the healthcare to the community where the patients were.
That's great. Thank you. So I think at this time I'd invite the attendees, if anybody has a question, if you want to put it into the chat. I think that, while we're looking, I'm trying to see if there's anything that's come across here. One question that was tagged for Becky: does your system do any test screening or processes, necessarily, or do they do some other basic vitals beyond that?
So we do, in some of the hubs, we will do EKGs, and depending on, you can do some simple urine tests and other things like that. So we do have a few of those things. But for the most part, we really try and use the local facilities to send through any ancillaries.
Makes sense to leverage the resources that are already set up in your communities. It keeps costs down and access is there.
And it's a non-threatening partnership, really. It'd be hard to partner with somebody who's going to come in there and kind of take those ancillaries out. We want to boost them up.
Yeah. So one other question. Let me ask of this. Are there any types of tech solutions that are best suited for older adults in rural settings? Anything we haven't touched on today, or anything that we should be thinking about?
From our experience, I think that app-based solutions where you have to download something for the telemedicine visit was a barrier. I remember one of the first help calls I got going into the pandemic was from an elderly gentleman that said, how do I get my thumbprint to work so I can download this app, right? So now I'm educating on how to use an iPhone before we can get to the app. So I think any, tech solutions that are web-based browsers that you don't need to download or have the bandwidth, the space to actually get that app to work are extremely beneficial.
That's great.
I think, one other kind of approach we took on, and it's a resource intensive approach, but for the right population, it ends up making enormous financial sense, is actually sending out patient, staff, community health assistants into the patient's homes with MiFis and stethoscopes and things like that. Again, needs to be very targeted audience, folks who are very high risk of readmission and ED utilization. But we actually found we were able to save quite a lot of money to the payers with that model. And the other thing I was just going to add on, kind of the previous question is, for the broadband access is, kind of the flip side of, what I was saying. Oh, it's great, we can get all these behavioral health providers, say in Central Pennsylvania, that we would never get otherwise. The flip side of that is the patients have to have broadband. And so if they don't, Geisinger would certainly offer a brick and mortar visit, but the access is very limited. So you may end up waiting much longer than if you had broadband. So I think, increasingly lack of broadband access really has to be thought of as a public health crisis. And so really, I think incumbent on, the health community to really partner with a lot of those, providers, and, a lot of kind of piecemeal grants out there, but, we really need to kind of pool our resources, I think, as much as possible and really kind of get this solved.
That's a great point. I think that's a great point to end on. So I want to thank our panelists for joining us today, for giving us their time and knowledge and expertise. So thanks to all of you. Much appreciated.
Thank you everyone for joining today. And this session has been recorded, and we're going to share it on our CE4TA website as well as our comms channels. And just to let everyone know, we have another upcoming webinar next Wednesday at the same time, and that is focused on hospital at home. And the link to register is here. And thank you for attending today.